Regarding the knee, we have a couple of interesting issues here. When we look at the knee, if we compare it to something we said about the shoulder, we said one of the reasons the shoulder was not stable was because you had a very large ball articulating with a very small flat surface. Well, that's exactly what we have at the knee. We have a very large convex femoral condyle articulating with a flat tibial condyle. Not exactly what you would call a ball and socket, right? Not very stable. Well, that's a problem for us because the knee needs to be stable if we're going to stand on it. And so if the bony configuration of the knee, that is the articulation between the femur and the tibia, if that bony configuration is not stable, then we have to add things to the knee to give it more stability. And so let's look at what we add, because it's the things that we add to the knee that most frequently get injured. So what do we add? Firstly, we improve the fit between the femur and the tibia by putting a meniscus in between. And the meniscus, what makes that a useful structure there is because the meniscus is flat on its inferior surface, but concave on its superior surface. So the flat inferior surface articulates with the flat tibial condyle. The concave superior surface articulates with the convex femoral surface. So we've now improved the fit by providing a concave surface for the femoral condyle to articulate with. So the congruity or the fit between those two articular surfaces has been improved, and that improves stability. So that's one thing we've added. Secondly, if we want to increase stability, a way to do that is to decrease mobility. And one way to decrease mobility is to reduce the number of directions in which a joint can move. In other words, reduce the number of degrees of freedom. And so we can reduce mobility by eliminating abduction and adduction, by putting ligaments on the medial and lateral side of the knee, collateral ligaments. So we have a medial collateral ligament, also called the tibial collateral ligament, and we have a lateral collateral ligament, also called the fibular collateral ligament. The medial collateral ligament prevents abduction of the leg. The lateral collateral ligament prevents adduction of the leg. We'll come back to that point in just a minute. Another point that I want to get to first is for you to notice the difference between the medial and lateral sides with regard to the relationship between the collateral ligament and the meniscus. Notice that on the medial side, the medial collateral ligament and the medial meniscus are fused together, right there. On the lateral side, the lateral meniscus and the lateral collateral ligament aren't even close to each other. They're so far apart that there's enough room for a tendon to pass in between them. So they're not fused. That's an important difference. The fact that the medial meniscus is fused to the medial collateral ligament. And the reason that's important is that that fusion to the collateral ligament limits the mobility of that meniscus. The meniscus cannot move around inside the joint, whereas the lateral meniscus can move around inside the joint. That difference turns out to be important with regard to the mechanism for tears of the meniscus. The way the meniscus typically tears is that while that limb is weight-bearing, if I'm standing on this limb, that means the femur is squeezing down against the tibia with the meniscus sandwiched in between. So femur is pushing down, gravity is pulling that down. Okay, so you're squeezing the meniscus between those two bones. If while you are doing that, a force is applied to you to force the femur to rotate while the tibia and foot are stable. So in other words, if your foot is planted in the ground, let's say you are a football player or some kind of an athlete wearing cleats, and your foot is planted in the ground, so your foot and therefore tibia won't move. And then somebody runs into you, causing your trunk to rotate, which will cause your femur to rotate. So what's happening is your femur is pushing down against the meniscus, squeezing it against the tibia, and then while doing that, it rotates. Well, what's going to happen is the lateral meniscus can move with the femur. As the femur rotates, the meniscus will move with it. But on the medial side, because the meniscus is fused to the collateral ligament, the meniscus can't move. And so now you have the femur squeezing and rotating at the same time against the meniscus, and that's what tears the meniscus. And so therefore, medial meniscal tears are much more common than lateral meniscal tears because the medial meniscus is pinned in place by its fusion with the medial collateral ligament. Now, a separate but somewhat related point is that because the medial collateral ligament is fused to the medial meniscus, if we were to have an injury that was a tear of the medial collateral, we'll talk about how that might happen in just a moment, but if you have a tear of the medial collateral, you can see how a tear of the collateral can extend right on into the meniscus because they are fused. So you tear this, it's common you'll tear the meniscus along with it. In contrast, the tear of the lateral collateral shouldn't have any bearing on the lateral meniscus because they're not connected. So we're saying two separate things. One is that the medial meniscus tears more frequently than the lateral meniscus, period, because it's pinned in place. But now we're also saying that the medial meniscus will tear along with the medial collateral, whereas that's not true on the lateral side. Now, what about tears of the collateral? How do they happen? Well, we said that the medial collateral in its position prevents abduction of the leg, and therefore the lateral collateral prevents adduction. But that's not really the way they get stressed. I mean, you don't usually have forces being applied that pulls the leg laterally or medially. It's usually just the opposite. Actually, usually what happens is the foot, again, is planted in the ground, perhaps wearing cleats, and then a force is applied to the knee. So let's say your foot is planted in the ground and some force, a large person, a 300-pound football player, comes running into the lateral side of your knee, driving your knee medially. Well, driving your knee medially is the same as driving your leg laterally, right? It's the same force. It's going to cause a stretching or a stress on this medial collateral ligament. That's called a valgus stress, right? This being the knee being driven medially with the foot planted is the same as the leg being driven laterally. That's a valgus stress, and that will stress or tear the medial collateral ligament. And in contrast, just the opposite, if that force was applied to the medial side of the knee while your foot was planted on the ground, then that would stress the lateral collateral ligament. That would be called a varus stress. That would stress the lateral collateral. Well, medial collateral tears are much more common than lateral collateral tears simply because it's a lot easier for somebody to run into the lateral side of your knee because the medial side of your knee is protected by your other limb. But the lateral side of the knee is exposed, so it's more common to have a blow to the lateral side, which would stress the medial collateral. Okay, so medial collateral tears are more common than lateral collateral tears. And we also said that medial meniscal tears are more common than lateral meniscal tears. One additional stabilizing structure that we're going to have in the knee are two ligaments that are on the interior of the knee, the two cruciate ligaments, the anterior cruciate and the posterior cruciate ligament. They are inside the knee, in contrast to the collaterals, which are outside the knee. These are inside the knee. Cruciate ligaments, and they're going to resist anterior and posterior displacement. So again, we're increasing stability by reducing the number of directions in which we can move. The collaterals prevent medial and lateral movement. The cruciates prevent anterior and posterior movement. To understand how they're working, it's better if we look at it from a lateral view. So on this schematic here, this is the anterior side of the knee, posterior, posterior. So here's the posterior cruciate ligament. Posterior cruciate ligament goes from the posterior side of the tibia to the anterior side of the femur. Okay? And the anterior cruciate goes from the anterior side of the tibia to the posterior side of the femur. Okay? So the two cruciates, anterior and posterior cruciates, are named according to their tibial attachment. Anterior cruciate, posterior cruciate. And you can see, looking at this, that the anterior cruciate would resist anterior displacement of the tibia. If I try to pull the tibia forward, the anterior cruciate would prevent it from moving. If I do pull the anterior cruciate forward hard enough, or if I have a blow applied to the back of the leg like that to drive it forward, that's what could tear the anterior cruciate. Recognize that pushing the tibia forward is the same as pushing the femur backward, right? So I can tear the anterior cruciate by driving the tibia forward or by driving the femur backward. So a blow to the back of the leg here can do it, or a hyperextension injury that drives the femur backward. Either way, I can tear the anterior cruciate. And then just the opposite for the posterior cruciate, driving the tibia backward or the femur forward. Anterior cruciate tears are much more common than posterior cruciate tears. The way you would test for the integrity of the cruciates is to try to pull the tibia forward or to try to push the tibia backward. If you try to pull it forward, it shouldn't come forward. If it does, if you get anterior displacement of the tibia, it means you have a torn anterior cruciate. And if you can push it backward, then you have a tear of the posterior cruciate. So we've said that the anterior cruciate tears more frequently than the posterior cruciate. We said that the medial collateral tears more frequently than the lateral collateral. And we said the medial meniscus tears more frequently than the lateral meniscus. Those three that are the more common of each pair would not be a surprise that they may all occur together in the same injury. And when that happens from a single injury, getting all three of those, that's what has sometimes been termed the unhappy triad. It's a common combination of injuries from blows to the knee, and that would be a tear of the medial collateral, medial meniscus, and anterior cruciate ligaments. Okay? All right, that takes care of the knee. The ankle, there's not a lot that we need to say about the ankle. Actually, if you just look at these two pictures, it really tells the story. There are collateral ligaments at the ankle. You see that the medial collateral ligament is a much, much more robust ligament than the lateral collateral ligament. And therefore, you wouldn't be surprised that it's the lateral collateral ligament that's much more easily torn because it's thinner and weaker. And so sprains or tears of the collateral ligaments of the ankle are most commonly on the lateral side, lateral collateral ligaments, which are inversion injuries. When you step down on the lateral side of your foot, forcing inversion, you can tear the lateral collateral ligament. It's usually this anterior band that most commonly tears. But it's the lateral collateral ligament that tears much more frequently than the medial collateral at the ankle. Okay, so we've concluded our discussion of the lower limb. We wanted to review the neuromuscular components of the limb, which we've done, take a look at the arterial supply, and look at the skeletal injuries at the hip, knee, and ankle.